Now into Chapter 3, first part, Part A, on what's known as pharmacokinetics, which involves the administration, how it distributes, where it binds, how it's metabolized, and then eventually how it's excreted. Now that we've taught this class for a few years, it's clear to me that for some of you, this class and things like pharmacokinetics or perhaps pharmacodynamics from last time feels very abstract to you, feels very departed from your area of care interest, shall we say, or the type of career in occupational therapy that you're particularly interested in. However, there is a rising understanding, a rising appreciation for something known as medication competence. And so understanding at least the basics of pharmacokinetics will help you to better design plans that you will help you do better therapeutic planning, better implementation, and certainly better observation and assessment of the patients as you're doing your thing. And here's just a brief example. You can read through this, but this is someone who is taking this drug called tenofovir, which is an antiretroviral. The problem is that, for somebody taking this for a long time, you can't take it orally. It has to be, injected intravenously. And so that's a life, if we're talking about a lifelong treatment, that's going to significantly impact their occupation. It's going to significantly impact their ability to do things because they have to be within range, so to speak, of parenteral. That's the term when you're doing injections that require some type of supervision. It's going to significantly impact their lives, and you're a part of that. I do have an article for you that I'm going to put up in ACE, just explaining this idea of medication competence. Even this can be in any direction that you head, whether you're talking about it from a professional standpoint, like in these examples, or even in a personal one. Understanding at least a little bit about pharmacokinetics will take you a long way into more asking better questions, being able to spot issues earlier than we might otherwise have. So what do we mean when we say the word pharmacokinetics? It's the study of how the drug moves through the body, moves into the body, through the body, and then eventually out of the body. So we have phases of absorption. That can be enteric absorption if you're talking about an orally bioavailable drug, or perhaps absorption through an injection or through the skin or other delivery routes. We have distribution. Where does the drug go? And there are what we call different compartments of the body. Depending on how hydrophilic or how lipophilic the drug is, you can have the drug distribute to more than one or two or even three different compartments in the body. We have the metabolism, which often occurs in the liver or may occur at the site of the tissue or perhaps occurs in the kidney. And then we have elimination, which can include either what we call the fecal route through the bile, or through the kidney through the renal route, or perhaps you can exhale it in some cases. Like for instance, if you've ever been around somebody who's had too much to drink, you can smell the alcohol in their breath because what's happening is the drug is moving into the airways and then they're breathing it out. It's not the sole route of excretion, but it's certainly one, or through the skin and so forth. So we have these four major phases: absorption, distribution, metabolism, which can not necessarily be in that order, and then finally elimination. This figure merely elaborates on the previous slide, showing not only absorption, which is when we finally get it into the tissues and the blood plasma, but also what we call administration, how we begin the process of absorption, whether we're putting it through the GI tract, through the skin, into the vein, muscular, into the cerebrospinal fluid, or even into the lungs in some cases. In any case, you remember how I mentioned different compartments? Well, certainly the plasma is one compartment, but we can also have other locations, for instance, fat tissue, cerebral spinal fluid, and so forth can make several different compartments. Then lastly, we have the elimination, like for instance, urine and feces are usual routes, though sometimes drugs will appear in other secretions, like for instance, sweat glands, or even breast milk or expired air. So this is just elaborating a little bit on what I mentioned in the previous slide. For a drug to be absorbed or distributed into different compartments, it will have to cross or be transported across one or more cell membranes. So we have our standard phospholipid bilayer here. We can have that, we have to be able to get that drug or that molecule across at least one, if not many different membranes. That's why many drugs are that, especially ones that we give orally, are relatively lipophilic, because they have to be able to move across a membrane of their own accord without a whole lot of assistance much of the time. In any case, though, there are drugs and there are ways of getting drugs into the absorbed into the system by things like by vesicular transport, like for instance endocytosis, or pinocytosis if we're talking about, for instance, a liquid. Pinocytosis, where we mostly see that type of absorption, is in the GI tract, in fat droplets, that sort of a thing. It could diffuse through channels, something we call facilitated diffusion. Maybe it's brought in by a carrier. It's like a channel, only it's a protein that makes it possible for a molecule to move across a membrane. They tend to be more specific. They're much more like enzymes than they are like channels. And then lastly, we have just straight up passive diffusion. Like this molecule right here got in basically by passive diffusion. So vesicles, liposomes, large molecules, it's not very common. You'd have to have a very specialized type of molecule that would mimic something that we would bring in by endocytosis or pinocytosis. You'd have to trick the body into doing this type of, because there are receptors and signaling involved. It's exceptionally specific, so not very common. So here's a picture of a liposome. Liposome is basically got a special, a cell membrane like phospholipid bilayer around it. These things can be generated artificially. Where we see most of this type of liposomal type delivery at this point is actually on skin, on the surface of the skin. In fact, there are cosmetics that take advantage of this. They're not pharmacologically active. Nevertheless, that's where most of this is going. I have seen some novel cancer delivery drugs that they're trying to do something like this, where they have a special kind of membrane that not only is a membrane, but it also has characteristics that make it more easily fusible with cancer cell membranes. Channels and carrier mediated is more common. So we have a molecule that is small enough and charged properly to get through a channel. Maybe we have a protein carrier. Again, that would require a little bit of molecular mimicry, if you will. But these things fall under facilitated diffusion if it's just a passive process. There are examples of active transport where you're using ATP to do some of this. So here are some examples. Here's our channel, for instance. Seeing things can get through channels. I'll give you a great example is lithium. So people who take lithium for certain types of mental issues, the lithium goes through channels that are already present in the cell membrane. Carriers can be, like I said, a little more specific, and they can be facilitated diffusion or they can be active transport. Again, they look similar to a molecule that we're carrying across. Then plain old passive diffusion, you pretty much need to be pretty small. You can't be a peptide type thing, like for instance insulin would never do this, or peptide hormone type things. And it has to be lipophilic. It has to be something that is able to get through that hydrophobic interior of a plasma membrane. Here are just some examples of what we were talking about in the previous slide in terms of moving across membranes. Our first example right here is nicotine, And nicotine's very, very small. It's very, very lipophilic. And so if there's any concentration gradient whatsoever, that drug will move across that membrane, no problem. And that's why nicotine can be applied as a patch on the surface of the skin, in addition to other ways of entry, because it's so small and so lipophilic. So no assistance needed for diffusion to occur down a gradient. If it's something small and hydrophilic, like for instance our lithium ion or some other type of hydrophilic small ion type molecule, it's going to need a channel of some kind. And again, we're not going to invest energy here. If there's a gradient, it will diffuse down its gradient, assuming there's a channel to facilitate that diffusion. I'm going to put a little conceptual divider here for you, because over here on the left, this is all passive. Carrier-mediated movement, however, can be both passive or either passive or active. And here's an example of a small amino acid-like molecule. This is actually levodopa. This is a precursor to dopamine. And levodopa, we know, has carriers that will allow it to move through the blood-brain barrier. Well, that's why we can't give dopamine straight up, because it can't get through this barrier. It doesn't have a carrier, but levodopa does, and it moves through this carrier. So on the left, we have exclusively passive, and on the right, these carrier-mediated transports can be either passive or active. If it's active, it's usually moving something up a concentration gradient, and you see ATP or something like that. And those of you who might have taken undergraduate physiology with me or another professor in the department, you might remember Fick's law. And one of the aspects of Fick's law was how soluble the molecule that's diffusing is in lipids. So if it has a high degree of lipid solubility, it will generally move down its concentration gradient. And here we have nicotine again. So Fick's law, one of the factors was how lipid soluble a given molecule might be. And remember our experiment with partition coefficient. That was playing directly into that lipid solubility. On the other hand, a larger molecule, like for instance insulin, molecular size and or lack of lipid solubility make this drug all but impossible to move through a plasma membrane. And that's why for insulin to work in a human body, there actually has to be a receptor on the surface, the outer surface of the plasma membrane, because this guy is not generally going to get inside a cell. And even if it could, it would be, the kinetics would be so slow as to be almost ineffective. So for rapid kinetics for something like this drug, you have to have an extracellular receptor. It's not getting through that membrane. So kinetics not only has an efficacy aspect to it, kinetics can also determine the onset of the effect of a drug or the onset of when the drug ceases to function. So for instance, this drug right here, thiopental, is a very, very good anesthetic. It's part of a family of drugs called barbiturates. Okay, and thiopental has very, very fast kinetics. That is to say, when you administer it to a human body, the onset of effect is extremely rapid. Why? Because it can fly through the membranes. But as it's metabolized, it will almost as fast move out of the tissues. So we can see a rapid onset and we can see a rapid diminution of effect. And so thiopental's general effect lasts somewhere in the neighborhood of around 20 minutes. On the other hand, something like pentobarbital has slower kinetics. It's in the period of 3 or 8 hours. Again, a little less lipophilic than thiopental. Thiopental is extremely lipophilic. Pentobarbital has a slower onset of reaction, and it also has a longer duration of effect. It takes a little longer for it to get into the tissues, and it will not leave the tissues very fast. It takes a while. That's why it has a slower off. And then if we look at barbital, the original member of this family that was identified, this one actually has half-lives of days. So if you administer this, it'll have a very, very slow onset of reaction and a very, very slow diminution of effect. That's because we're going to be in the effective concentrations for longer because it diffuses so much slower out of the tissues. It's much less lipophilic. Here's one of the trickier slides in this presentation. And it has to do with the fact that drugs are not statically hydrophobic or hydrophilic. Their hydrophobicity or lipophilicity, that means the same thing, or their water soluble characteristics can change depending on the pH environment. That's because many drugs are weak organic acids or perhaps weak organic bases. A lot of our drugs are plant derived from the environment, and so they have functional groups that can change the lipophilicity or the hydrophilicity of the drug depending on the pH. And so let's look at first organic acids. In a low pH environment, that is to say lots and lots of H+, those of you who took my class might remember the law of mass action. What's going on is that weak organic acids like this will actually lose or gain that proton depending on the pH. So in a low pH environment, like right here, what we're going to see is more H conjugated to that COO group, thus leading to an uncharged molecule that's much more able to penetrate a plasma membrane. If we turn around and make it more alkaline with very little H+, that H will dissociate off, and now we find ourselves in this form where we have a COO-. This is a charged drug. This has a weak ionic charge, much less likely to penetrate a plasma membrane or a tissue membrane. And the opposite is true of bases, so I don't want you to get confused here. With the bases, for instance, if we're in I'm going to start with the bottom here. If we're in a low pH environment, again, with lots of H+, it will push an extra proton onto this, in this case, an amino group. Now we have NH3+. So this is charged, much less able to move through a plasma membrane. So a low pH for acids means it's much more able to move through a membrane. Low pH for bases, much less able to move through a membrane. And then vice versa. If we go to high pH, what we see is we lose that extra proton, and now we're back to our neutral situation, uncharged, much more lipid soluble, and much more able to penetrate. Where does this really matter? It matters on the drugs that we deliver orally. There are some other drugs for cancer and some other things out there that they're trying to use this also, but this is really big when it comes to oral agents and the acidity or alkalinity of the environment where that drug is. And that will dictate whether the drug gets in through the stomach or it gets in through the small intestine or the colon in some cases. So, if we have an acidic drug, a mild organic acid, what we will see is that when it hits the stomach, that low pH environment, it will be absorbed by the stomach. So we'll see drugs, mild acidic drugs, I'll do those in red here, will move out through the stomach, which means that it might have an earlier onset of action than we would see another drug that maybe is in fact a neutral or a mild base. So drugs that are formulated as a basic molecule that has like an amine or something in neutral or high pHs, you're going to see absorption occurring in these areas right here. I should do those in purple, so I'll do that one in purple. So what we would see is intestinal absorption with drugs that have a neutral or high pH configuration. So mild bases or neutral drugs will be much more likely to be absorbed in the small intestine or the colon. That's why we would understand that, why something may have a more rapid onset or stomach absorption or intestinal absorption or colonic absorption. And so the absorbability of a drug, the kinetics of a drug, the ability of a drug to penetrate depending on the environment, all factor into how that drug is administered. There's no point in giving an intravenous drug or an intramuscular drug if we can give it in a much less painful way, for instance, enterically. So we have drugs that we can deliver through the oral ingestion that then get into the bloodstream via the liver and the hepatic circulation, or we have to use other administration because it's not orally available. We can even, if something's very, very lipophilic and we want it to be a localized administration, maybe we can apply it topically, maybe we can inhale it if it's penetratable, and so forth. So the drug administration is often determined by its ability to be absorbed by a certain tissue or certain surface of the body. Just a quick list of some things which will impact and influence how a drug is absorbed and where it distributes in the body. First of all, how we deliver that drug to the body. For instance, you might be able to deliver a drug intramuscularly or intravenously, or perhaps even through the lungs. Insulin is an example of that. You can deliver it intravenously, you can deliver it intramuscularly, or you can even inhale it. That However we administer that drug will affect its ability and to get into the bloodstream and impact its effect. Whether or not a drug is administered, if it's orally, with food or fluids. Okay? If you have food or fluids, that may change the pH of the stomach, or it may change the pH of the small intestine and will affect drug absorption, which is why sometimes they'll say take with food or take with water, that sort of a thing. Exercise can have a huge impact. This is one I would want you guys to pay attention to if you're dealing with any type of exercise therapy. You want to make sure that that there aren't any contraindications with any type of manipulation or exercise. We're talking about cardioactive drugs or massage in the case of insulin, that sort of thing. The formulation, we have fast-acting formularies, we have slow-release formularies. Those can have an impact on how fast and how the drug distributes. Then we may have issues with the surface. This kind of gets back to Fick's law a little bit. If you have for instance, let's say we have a nicotine patch and you put it on a spot where there's a lot of calluses or a lot of scar tissue, maybe that patch won't be as effective because of the status of the absorptive surface. Or if somebody has a chronic inflammatory bowel disorder, now they can't absorb things properly. Now the drug may not be as effective. Just examples. Blood flow to the small intestine, kind of along the same lines as that absorptive surface. If you don't have good blood flow, that could affect or impact the effectiveness of the drug or how it gets in. Acidity of the stomach. Lastly, GI motility. So if somebody has diarrhea, the drug might pass through and not be absorbed, or if they have constipation, you might see an augmented effect. But these should all sort of make sense from the idea of blood flow and or diffusion, or in the case of administration, whether we're just putting it straight in the bloodstream or not. Since we are running a little long on time, I'm going to move through these slides a little bit quicker. I'll try to point out points of emphasis for you as we go. We're going to go through the different types of routes of administration, and we're going to start with what's called the enteric or the oral route. So the drugs are going to be administered, usually swallowed, sometimes chewed and so forth, sometimes just a lozenge on the inside of the mouth and so forth. This is known as enteral route of administration. It's often the easiest way, unless the person has issues, like if they can't swallow or they're unconscious, then that doesn't really lend itself to self-administration, if you know what I mean. But for a normal functioning person or someone who has generally good function, it's the easiest way of administration. But it's also the most complicated. Why? Because we've got solubility issues. Where is it going to be absorbed? Is it a mild acid and going to be absorbed in the stomach, or is it a mild base and going to be absorbed in the small intestine or the colon? How well is the GI functioning? Do you have inflammation? Is there food or water present that can dilute the drug or alter its absorption profile? The other thing about enteric delivery is that a lot of the drug is lost before it ever gets to the tissues where it might be serving its function. And that's due to the fact that the liver, it's called the first pass effect here, that the liver actually, because the blood moves from the small intestine to the liver via the uh, the hepatic portal vein, the liver will often metabolize and remove drugs before they ever reach the tissues. That's known as bioavailability. That is to say, the percent of drug that actually reaches circulation. And in the case of oral routes, that bioavailability is generally 1% to 10% at max. So if you were to take 1,000 milligrams, you might only see 100 milligrams at most ever make it. And usually it's closer to 1 to 5 milligrams. So oftentimes you have to take bigger doses if you're taking it orally. That's why some of those antibiotics that you might take orally are these big horse pills, because they get screened out by the liver. They have low bioavailability. If they have very low bioavailability, if they are essentially screened entirely out by the liver, that usually means that you're going to give an injection into the blood so that you're basically bypassing the liver and getting it out into the bloodstream. So very low bioavailable drugs often have to be administered in some other way other than the gastrointestinal tract. So here's a picture showing you this idea of first pass metabolism. That's the term. When you give a drug into the intestinal tract, it gets pulled out of the small intestine and goes through the liver first, where it gets metabolized. And so if we're lucky, we'll see maybe 20% of the 90% or the 100% or so forth making it through here, and we might see 10 to 20% max. If you saw 20% bioavailability, that would be a pretty good drug to give orally. Okay. Oftentimes what happens is in that first pass metabolism, the drug is modified in some way. That's what drug conjugates means. You've tacked on some functional groups that target it for renal secretion or so forth. So in any case, this is an example of why potency tends to be lower when you give drugs enterically. This first pass metabolism lowers the bioavailability of drugs. Here's the really hard and fast rules for you. If you're going to be assisting anyone, maybe it's a client or a patient, maybe it's your elderly parents, or maybe it's your young kids, here are some hard and fast rules to take away, and I want you to pay particular attention to these hard and fast rules. First of all, if you have an oral enteral type agent that's meant to be ingested orally, avoid crushing them unless you have specific approval from the physician, or if the manufacturer's literature says it's okay to crush. The reason why is when you crush a tablet, you certainly disturb the coating on it, but you also affect the absorption profile and the onset of effect where that drug might be absorbed. So unless there is specific approval either in the literature or by the prescribing authority, do not crush tablets. It can be very, very tempting if you have kids that just won't swallow that pill. Don't be afraid to ask if it's okay. Secondly, if it's a sustained release agent, or what we call an enteric coated tablet, or it's a capsule like a liquid capsule, never ever chew, never crush those. Again, you can sort of fall back on the idea if it's okay, but generally speaking, the reason that they're formulated this way is so that they're specifically absorbed in the enteric system for sustained release. If you crush those drugs, all of a sudden you have rapid onset of absorption, and that can cause toxicity. So we don't want to open capsules. We don't want to chew or crush drugs and formulations that are deliberately sustained release. Sometimes posture can be very, very important. This is often why we'll give drugs in the morning, so that the person is more likely to be upright and active during absorption, or maybe why we give something in the evening right before bed, because laying down in the posture can affect absorption. So sometimes posture is important, and again, you're going to want to pay attention to that if there are any specific instructions about that. Most oral agents are designed and formulated to be better absorbed and with better kinetics if you take 4 to 6 ounces of water. That is to say, about half a coffee cup of water or so. The coffee cup is generally 8 to 10 ounces. A big coffee cup is closer to 10. A standard coffee cup is about 8 ounces. So a little bit, 2/3 of a coffee cup. Have them take that water. I'm as bad as anybody. If I'm just coming back from a run or something and I want some ibuprofen, I'll just dry swallow that pill. That leads to less effective kinetics of the drug, and so I'm actually not getting the pain relief that I would normally get by dry swallowing that ibuprofen. So if I take a little bit of water, I'm more likely to feel better. So most oral agents are good to take with water. It'll ease the swallowing of the pill and will certainly improve the absorption kinetics. There are agents that are designed to be put in the mouth, but they're meant to not be swallowed. That is to say, you put them sublingually, like for instance, nitroglycerin tablets, nitro tablets, or are meant to be sucked on. They're buccal. They have different rules. They're generally not meant to be chewed or swallowed. So again, instructions. I'm looking at my time right now and I'm just hit the half-hour mark. So I'm going to stop right there. I thought I could get through the slides a little quicker. I apologize for that. But since oral administration is so important and so common, I slowed down more than I realized. I'm going to stop right here and I'm going to pick up again with the additional routes of administration in part 3B. So I will see you soon.